All right, well, everybody, I'm Carrie Zografos. I'm a second year internal med resident. So you guys are all Zoom champs here on this snowy day. I'm probably going to turn off my video while I present just for like Wi-Fi's sake. So let me know if the audio starts to cut out at all. Okay, sorry. It's been a really long time since I've done any presenting on Zoom. So all right. So today my topic is addressing disparities in women's cardiovascular health and care. It's definitely a topic that I'm very interested in. Um, but I do just want to acknowledge, this is a very sensitive and traumatic time for many of us, especially with diversity, equity, and inclusive initiatives are being just slandered and gutted. Our marginalized communities are being politically scapegoated as well. And I think it's important to continue to stand up and speak out to fight this injustices and inequities as well. And also just acknowledge that health disparities exist because we live in a country rooted in white supremacy. And our culture and society works hard to maintain the status quo. So as a result, we have these racist, misogynistic, discriminatory structures and systems that have been built and continue and leads to poor health and access to care for so many. And I myself am not an expert in cardiovascular care or health equity for that matter. This is just from my perspective, but of course, I tried to always look at it from the broadest lens possible and decenter myself. But, I'm a very privileged middle-aged white lady in medicine, so I don't claim to be a spokesperson for anybody. But I do believe that this burden is all of ours to shoulder to address inequities in healthcare. Just my acknowledgements are Dr. April Stempian Otero. She is in the area of heart transplant and heart failure, and she has a really big interest in addressing differences in cardiovascular outcomes and care and just sex differences in general in our cardiovascular system. And then Dr. Jonathan Buber, he is another mentor of mine, and he's an adult congenital heart disease area, but he also does a lot with cardio obstetrics and caring for pregnant people with heart disease. Oh, so if you guys all want to humor me, I made this Slido, never made a Slido before. And if you can give it a try, if we have too many technical difficulties, we'll just move on. But the question for you all to assess in this moment is just what do you think of when you think of what comes to mind when you hear about disparities in cardiovascular health and care in women in particular? Oh, sugar. Sorry, guys. Guys, I lost it. Back. Yeah, so I'm seeing disparities in chest pain diagnosis, frustrated menopause effects on cardiovascular disease. Yes, anxiety, persistent research, or disparities in research. Yes, we'll talk about that. Underdiagnosis. Yeah, atypical ACS symptoms. So, yes, All right. So this is kind of the lens that I'm looking at through, from these different perspectives when I'm kind of looking at cardiovascular health disparity. I'm looking at it from our patient perspective, our professional perspective, and then research, both in our participants and research investigators, which a lot of you already highlighted there. And just to, and why these disparities are important, because they impact our treatments, they impact our research, where our dollars go, and not that I need to tell you guys all of this, but which impacts the pathologies that we are investigating, the treatments that we're developing, the outcomes for our patients, the access and care for our patients. Heart disease in the United States anyway, started becoming more and more recognized, just increased incidence in the 1950s, 60s. People were having myocardial infarctions. And at that time, it was really considered to be a disease for men. And here, this is from the American Heart Association, published in 1968, a nutrition public education pamphlet titled The Way to a Man's Heart. And at this time, heart disease was considered a man's disease. If women had a role to play, it was taking care of the men in their lives. This is from the American Heart Association, hosted a conference in the 1960s themed "How Can I Help My Husband Cope with Heart Disease?" and published this nutritional pamphlet. So it speaks to a lot of things. First of all, the assumption that if you're a man, you have heart disease, that you must be married to a woman, and she is more than likely going to be taking care of your nutrition, and therefore her role to play in heart disease is how to best feed you, care for you in the man's heart disease. However, over time, it happened about in the 1990s or so, people started recognizing, and cardiologists started recognizing that cardiovascular disease was in fact happening in women as well. So this was not until 1997, this was published. And this is because we started doing more studies in the early 1990s, looking at heart disease in women in general before they were ignored for a while. And what this is showing us here is that here's the deaths in thousands from cardiovascular disease. The women we see is this checked line up here, and the solid line is men. And what we were seeing was just increased mortality among women. And this was back in 1993. This was published in 1997 by the American Heart Association. It's a scientific statement essentially for just raising awareness amongst health professionals that yes, indeed, women also have cardiovascular disease. And just for a little bit more context for myself, I graduated from high school in 1998. And then this was soon followed by some guidelines on preventative cardiology for women in terms of risk factor management, which is still obviously how we address a lot of cardiovascular disease to this day. But this was published 2 years later in 1999 by the AHA and the ACC. Was the first women-specific clinical recommendations for prevention of heart disease. Purpose was just to highlight this risk factor management. And after seeing that there were risk factors that women were more predisposed to, whether that would be diabetes, smoking cessation was less common among women actually, and then also they were finding just higher levels of cholesterol and also less treatment of that in women with heart disease. And so in the early 2000s, I remember this very, very well. There was a big public push to help the public understand. They had already felt like that they were educating healthcare providers, and now people wanted to educate the public about cardiovascular disease as the leading cause of death in women. Because really at that time, a lot of women and people in general thought breast cancer was the leading cause of death. The Susan G. Komen Foundation was really strong in the 1980s and 1990s, and their big push was raising awareness for breast cancer. And then, we talk about bikini medicine too, which I know what people have talked about in the past, and the idea that reproductive health is the primary health that we should be addressing in women. So this was like the Heart, Blood, and Lung Association here. They launched their campaign, The Heart Truth, in 2003, and Go Red for Women, which was by the American Heart Association in 2004. And that was the initial first launch of this. It still goes on today, but of note, in 2004, it was reported that only 34% of women knew that heart disease was their #1 killer. This red dress became a symbol for heart disease for women, which is a whole nother discussion in terms of medicine's perspective on women, but that's for another day. And then this is looking at some disparities amongst the profession of cardiology. So this was published back in 2019. It was data going up into like 2016, which I'm sure there's more data coming out now. But looking at that, women were represented in internal medicine residencies at 42%, but only comprised 21% of fellowships at that time. And then just of note, 9% of interventional fellowships, as well as 13% of electrophysiology. Additionally, physicians from underrepresented minoritized groups comprised only 12% of cardiology fellowships at that time, and 8% of practicing cardiologists. And this study didn't break up amongst women what the race and ethnic disparities were. But this is the graph you can see. So this is looking at fellows, physicians and cardiologists from 2006 to 2016 by sex. So this top upper left-hand corner, you can see that 80% of fellows were male, identified as male, and just at 20% of female up until 2016, and really like very, very plateaued, right? Not too much movement from the time of 2006, when this was kind of first identified as a professional goal to try to impact this. And then on the other side is pediatric cardiology fellows by sex, and they actually did make quite a difference in theirs, although their disparity just wasn't as significant. And then looking at adult cardiologists by sex as well, men make up just under 90%. Just under 90%, and women under 20%. And again, this is back from 2016. And then this is looking through the lens of race and ethnicity. So this here on the cardiology fellows by race and ethnicity, here we have those who identify as white, those identify as Asian, and then quite a disparity for the other groups included here, which going back to, there we go. This one that's right at 10% is identified as other, but the remainder, well under 10%, is Black, African American, Hispanic, Latino, or Spanish origin, American Indian or Alaska Native, and Native Hawaiian or Pacific Islander. And then you can see how that compares again to the cardiologist right below that. And again, a lot of those are also plateauing. So just to highlight a little bit about women in cardiology today, a few people that I just kind of found historically that I just wanted to discuss. Dr. Nanette Wenger, she is at Emory. She's been a cardiologist since the 1960s. She studied medicine in 1950s. She was very early as a woman in medicine, as well as she went to Harvard. And she's still in her 90s today, as far as I know, still alive. And she's still doing a lot of work in addressing disparities in women in cardiac care. And this is also Dr. O'Feely. So she is at Morehouse School of Medicine, and she's also a cardiologist. She does a lot of work in highlighting the need for more research, care, and improved outcomes among our Black patients. And she was the first woman president of the Association of Black Cardiologists in 2002. And she is still working hard today as well. And she actually has a study that she's working on, a large study focused on the health and outcomes of Black patients in particular. And then this is Dr. Alexandra Bastiani. She's someone I follow on Instagram. She is a doctor influencer, I guess, but she's also a cardiologist. And I think something that's so notable about her is that, and just kind of points to the time, how much medicine hasn't changed over the past several decades. I was a brand new nurse back in 2003. And I've been in healthcare for 20 years. And the truth is that not a whole lot has changed over that time in terms of this. But she was the first Black female interventional cardiologist in Canada just in 2020. But I have a video to share where she speaks herself. So I'm hoping it works. There's going to be a little ad at the beginning.
Get ready for Super Bowl licks.
No, that's Super Bowl 59, Gronk.
Ah. It's going down
Sorry,
live.
Gronk.
Very late in my training that I realized that I wasn't really focused on that.
Something else the 34-year-old didn't realize? That Prime Minister Justin Trudeau celebrated her achievements at the start of Black History Month, calling her an advocate and trailblazer.
He said my name. I'm going to say it. I'm proud. It takes a lot for me to say that word.
Dr. Bastiani, who was raised in Montreal, is working in a field that doesn't have a lot of diversity. She tells me there are only a handful of women and doctors of color.
I'm Haitian, of Haitian descent. So I can tell and I can feel that it's really important for my community and also for people who aspire to do what I do, or at least even just to become a doctor or physician.
And the journey from dreaming to the reality of now working in Thunder Bay wasn't easy, traveling on a road that lacked diversity.
My bosses basically did not look like me, did not understand my reality as a Black student, did not understand my reality as a Black person, period.
She also faced microaggressions, including while training in her field in Edmonton.
I came across a few patients that some of them refused. They were like, we want the senior cardiologist. I mean, I know why. Either because I was a woman or because I was Black. I try not to take it personally. But I realized with time that it's time for a change.
She says her profession knows there needs to be more diversity, and that's something they're working to improve.
We're working hard to raise awareness about this issue and also, find solutions.
She credits her family and a support system of allies who she says helped her and protected her.
I made it, and I really want to highlight the fact that I had amazing mentors, and not all of them are Black. Actually, most of them are white male.
But now the roles have flipped, and she finds herself mentoring others, students who reach out to her.
I try my best to answer and to help them and, tell them, hey, you can do it. Because just to hear that from someone who looks like you, who looks like you and who made it, for me, I think makes a difference.
Dr. Bastiani is also an advocate for women in medicine and for women receiving cardiovascular care.
Oh, sorry. Is anybody there? Oh, perfect. Thank you so very much. Okay. Okay. Get rid of that. All righties. So this is just to highlight a little bit of leadership at University of Washington. Dr. Stout, she was the founder of Adult Congenital Heart Disease Program. Dr. Oyatunji, she's a cardiac surgeon in our cardiac transplant department. Dr. Otto, a specialist in valvular disease. Dr. Minami, she specializes in heart failure as well as cardio oncology. And then Dr. Poole, she's electrophysiology director. Um, And then I just wanted to just touch on a few of our cardiology fellows as well. Dr. Danik Karasaki, she's an interventional cardiology fellow. She's an IMG. She's from Czech Republic, although she's lived all over. And I asked permission to share a little bit about both of these people. And for Barbara, so she is, as I said, is one of our interventional cardiology fellows. And her interests are in structural interventions as well as coronary physiology. Dr. Andrea Diaz, she's a first-year CARDS fellow from our internal med program. I know many of you know her. And she is a Peruvian immigrant, and she grew up in a very, very small town. She said about 3,000 people. And then her clinical and research interests are let's see here. Disparities as well. And then the next point of interest is research participants, which I'm just going to go through quickly. But essentially, as I'm sure you all are aware, there's really a lot of talk about it, but women just are not represented in research of cardiovascular studies, as well as a lot of people of color and minoritized groups in general in the United States. One research study that's very popular that really helped shape a lot of cardiovascular care is the Framingham Heart Study. So this was started in the 1940s, and you can see the different cohorts here, the 1970s, 2002, and later. So if you have no Boston area, Framingham is right outside of Boston, but this study initially comprised really mostly, vast majority were white men and women, and this kind of helped initially guide a lot of risk factor management for cardiovascular care. Since though, in the past two cohorts, they have made a lot of efforts to increase the diversity amongst those two cohorts. But this was a study that really was just concentrated in this one city in Massachusetts. And this is where a lot of women's cardiovascular research initially came from as well. And again, mostly white women. But as of the last few years in particular, there's just a big push trying to enroll a lot more women, a lot more patients from marginalized groups, and that just takes a very concerted effort from all around. And I think it just speaks to disparities amongst professionally and research investigators, which is the next section. So in looking at NIH awards for research grants, male versus female, the lighter blue is those that were awarded to male, and then the navy are those awarded to female. So you can see the discrepancy there. 40% are female currently that are awarded grants, and it's increasing over time. But, as we know, researchers' identities and backgrounds do impact our life experiences, which informs our own perspective and kind of where we step off from when we think about research in general. And then those who identify as Black or Hispanic are underrepresented in STEM degrees in general. And that's from bachelor's degrees, master's, and doctoral degrees. And this has impacts on, as a researcher, our area of interest, the questions we ask in research, our implicit, explicit bias, enrollment of participants, how our participants are trusting us, and then our follow. As I said before, it is the leading cause of death, which is the same for men. Cancer is the second, and actually stroke on this one is the fourth down, which stroke you could, also put into a cardiovascular arena. But this was a recent study in 2019 where women were 74% less likely to identify cardiovascular disease as leading cause of death. And that was increased amongst younger women and those who self-reported as non-Hispanic, Black, or Hispanic. And then also just looking at doctors, both in primary care and cardiologists, 22% of primary care physicians and 42% of cardiologists reported they felt extremely unprepared to assess cardiovascular risk in women. And this was recently published in 2021, looking at kind of more sex-specific risk factors for women. In the middle, you see the well-established risk factors. We have hypertension, dyslipidemia, diabetes, obesity, and actually those risk factors are also different between men and women. And then some more sex-specific risk factors, premature menopause, gestational diabetes, hypertensive disorders of pregnancy. I'll talk about that some more. And then actually this next slide, so this was looking at cardiovascular risk factors in women with impact of race and ethnicity. So from this perspective, it looks at the traditional risk factors, female specific, as well as pregnancy related, and takes into consideration social determinants of health, cultural issues and norms, and language and health literacy. So the first thing I want to talk about is hypertensive disorders of pregnancy. We are finding that hypertensive disorders of pregnancy, which includes chronic hypertension during pregnancy, preeclampsia, eclampsia, and gestational hypertension, that this is actually an independent risk factor for future cardiovascular disease for women across their lifespan, as well as increased risk for cardiac events during pregnancy and postpartum. We see increased incidence of chronic cause as white women. So this has been a big push to look at more cardiovascular disease within pregnant women. And so what this means clinically, so I was talking to Dr. Buber about this a little bit more, but pregnancy history should be included in medical histories, which I work at the VA, so I don't see a lot of women outpatient, but honestly, every time I've had a woman come in for chest pain, I've never asked her a pregnancy history. I've never asked her if she had preeclampsia or gestational hypertension, and additional risk factors to consider is also gestational diabetes, premature births, history of intrauterine growth restriction, and then small for gestational age should also be included in that. But we do know that hypertensive disorders of pregnancy is a major risk factor for cardiovascular disease. And then we don't have like guidelines on this quite yet, but Dr. Buber was saying that for women that do have a history of gestational diabetes and or hypertensive disorders of pregnancy, that they should follow up with cardiology every 5 years. And they should also have very aggressive risk factor management with LDL goal less than 70, looking at that blood pressure goal, lipoprotein A as well. So that will be guidelines in the future. And then MINOCA is another condition that we see women overrepresented in, and this is the MI in the absence of coronary artery disease. I have not had anyone actually diagnosed with this so far, but I'm sure many of you had. But 5 to 6% of cases with ACS referred for coronary angiogram. We see it in 5 to 6% of these cases, but maybe as high as 15%. And what it is it's a myocardial infarction in the absence of obstructed coronary disease, and of course, ruling out anything else that could be contributing to this. So it's a clinical diagnosis, and the underlying etiology does need to be determined. But people may present with less severe ST changes and troponin elevations. The average age is a little bit younger, 58, compared to those at 61 with obstructive CAD. And this is disproportionately seen in women. Near 50% of cases are women compared to 25% in obstructive CAD. And also more likely to occur among people who self-report as Black, Maori, or Pacific race, or a Hispanic ethnicity. And you may see that they also have less traditional risk factors, such as the one listed. And the reason why it's important is because, I think that ACS and this is just a flow sheet. I'm not going to go through this, but essentially that you do have to make sure that when you don't see an obstructive disease, then you have to make sure there isn't any other underlying etiology other than Minoka. And then SCAD is another condition I also have never seen, but this is a non-atherosclerotic, non-traumatic cause of acute MI and sudden cardiac death. The classic patient would be a middle-aged woman with few traditional cardiovascular risk factors, but it is observed across the lifespan. And again, this is women comprise 87 to 95% of patients. The mean age is 44 to 53. In this research study that I have cited, the majority of women were white, but this was a large case series done at a large academic center, and they had noted that other population-based studies did show similar presentations and outcomes amongst Hispanic and Black women. So that finding that it was overrepresented in white women is likely due to inequity and bias in recruitment and enrollment and referral at this research center. And then this is used to be seen as very, very rare, which is still considered on the rare side, I suppose. But 4% of patients it's seen in about 4% of patients presenting with acute coronary syndrome, and seen about 35% of women with ACS less than 55 years old. And what it is essentially is, you'll see on the right side here. So there's this intramural hematoma that forms, and so this is a about this as well is that in coronary angiography can actually cause more problems. So again, this is somebody that would go for cardiac cath if it's not suspected, and maybe even so. And Dr. Buber again was saying that really, so if even in coronary angiography, when the dye is pulsed through there, it can actually cause a propagation of that dissection and worsen this condition. And again, even with stenting, although it looks like that sometimes stents, they can be treated with stenting, but Dr. Buber was saying overall, it errs on the much more conservative management, and then also just managing, angina, so anti-anginals, plus blood pressure management. And then this slide is showing on the left, you can see here on the lower, the area there is where the obstruction is. And then later on, this was like 6 months follow-up that it had resolved. And then HFpEF is another condition that women are overrepresented or have an increased burden of. So on the slide on the right, it shows heart failure versus HFpEF and by sex. So the top blue line is HFrEF in men. So they are having the highest cumulative incidence. And then the HFrEF in women is the green, so that's kind of the middle one between those two on the bottom. And then HFpEF in women is this orange one right above the green one. And you can see compared to men in sort of like that purple color. And why this is significant as well, I think, is because even when we're treating HFrEF and HFpEF, HFpEF has just so many different modalities of treatment. These are people that are getting heart transplanted. They can go on balloon pumps. They can there's so many different medications. We see improvement over time with their GDMT if possible. So there's a lot of different modalities of treatment for them, whereas HFpEF is not quite as much. It's been studied less, and there's less treatments available and less randomized controlled trials. And it is interesting because even when we hospitalize folks with HFpEF versus HFrEF, or just talk about them differently, I find that there's this bias within the care where it's like, oh, it's HFrEF, so there's something we can do about it. That we have all this GDMT that we can titrate and manage, and it's sort of like a real heart failure, whereas HFpEF sort of gets sidelined a little bit and just sort of regarded as like, well, it's this HFpEF, there's something we can really do. So it seems a and this is just the treatment regimen. And this is just one of my final slides here by Wenger. She's one of the cardiologists I mentioned and monitoring progress. And of course, there's just so many disparities I could have talked about, but this is just where I wanted to start. And oh, so that wraps it up. This is just a cardiologist and novelist. She's somebody else I also follow. And I think it's so unique to find a doctor who also writes novels. She writes these romance novels. Her most recent release was Between Friends and Lovers. I have it, I have not read it, but she's also someone you guys can check out. And then just, Coffee and Cardiology podcast. Also, we'll talk a lot about UW, our leadership amongst UW. If you're curious more about the profiles of the faculty here, Cardio Nerds is also a great resource if you have other interest in cardiology. They are very nerdy, as they say, but they take on a lot about like cardio rheumatology, cardio oncology, and they have a lot of different sets of podcasts for our learning. And that's it. That's all I got.
Thank you so much, Carrie.
Yeah, of course.
I opening it up to questions.
Yeah, questions or comments. Oh, thanks, guys.
Yeah, lots of amazing things about thank you and saying it's amazing. Also, a comment for me is I learned from a patient actually how important it is to ask about gestational hypertension and gestational diabetes. And thank you.
Really?
Well,
Yeah. Definitely something we need to integrate more for sure. And maybe a lot of people are already doing it, but I know I haven't been. All right. Well, thanks all.